Good morning. I'm Brad Call from Washington University in St. Louis, and today I'm going to talk about where are we going with mantle cell lymphoma therapeutic strategies. I'm really going to focus on the frontline management of mantle cell lymphoma, attempting to do brief summaries of what are the current standards, and then really try to have an eye toward the future, highlighting some of the existing trials that might change practice going forward. Here are my disclosures. So these are sort of my overarching treatment considerations when I'm managing a patient with mantle cell lymphoma. I assume that the disease is generally incurable, and so like other incurable lymphomas, you really need a strategy for long-term disease management, and that forces you to think about how you're going to sequence your therapies. In general, if a patient is older and needing treatment, I typically recommend a non-intensive strategy, and I'll get into what I mean by that. If a patient is younger and needing treatment, I typically recommend an intensive treatment strategy, and the reason is it generally produces longer first remissions, although admittedly it's not 100% certain that that translates into an overall survival benefit. And there is, of course, a toxicity trade-off when using intensive treatments. And then for situations where I'm really on the fence between intensive and less intensive, that's where I might try to factor in the MIPI score and biologic factors like the Ki-67. And just to remind you, this picture shows outcomes based upon the MIPI combined with the Ki-67. There's 4 features that are prognostic in the mantle cell IPI: age, performance status, white blood cell count, and LDH. And then when you combine that with the Ki-67, and anything above 30% is associated with the worst prognosis, you can plug that into an online tool, and for an individual patient, you can estimate their long-term overall survival. So let's start by just thinking about how we might manage older mantle cell patients, and I've just listed here some reasonable options that investigators around the world might go to, and let's just look a little bit at the data supporting each. So I just tried to summarize in one slide here. There's actually a lot of experience with the R-CHOP regimen now, and it's pretty clear that this is not the best regimen for mantle cell lymphoma, with median remission durations of only 12 to 18 months. The VRCAP regimen, which subtracts vincristine and adds bortezomib into the regimen, produced much better results in a randomized phase 3 clinical trial with median progression-free survival of a little over 2 years. But I think better results can even be realized with the bendamustine rituximab regimen, and I've pooled data from 3 different trials which suggest that the median progression-free survival is in the 3 to 4 year range with bendamustine rituximab, and that's with no maintenance therapy administered. And then we have perhaps a glimpse of data that there might be other promising regimens. These were from single-arm phase 2 trials with a limited number of institutions. The RBAC regimen, which incorporates low-dose cytarabine, produced very high complete remission rates and durable remissions. And the lenalidomide rituximab regimen, published in the New England Journal of Medicine, generated high complete remission rates and very durable remissions, although I would point out that the R-squared regimen includes a maintenance component to the regimen. So perhaps not a fair comparison with these other regimens, which are just administered for 6 months in a time-limited fashion. There was a very recent publication from the group at Vancouver, British Columbia, looking at their experience using bendamustine rituximab for mantle cell lymphoma. They have almost 200 patients now, and I'll just focus your attention on panel C here, just looking at how BR performs in people over the age of 65. And again, this just suggests that you're on average going to be able to achieve remissions lasting more than 3 years in remission on average. So kind of supporting and validating previous work for bendamustine rituximab in this older patient population. So Bendamustine rituximab appears to be a solid platform. Not much reason to use R-CHOP anymore. If you can't use BR for some reason, the VRCAP regimen is reasonable. If I have an older patient with very proliferative disease, then I might lean towards the R-BAC regimen. It's very myelosuppressive, so I don't like it in general, but in certain high-risk cases, I will go to that. The R-squared regimen looks very good. The question is how much of this is due to patient selection in a limited institution prospective clinical trial, how much is due to the indefinite therapy, but this regimen, which is not FDA approved in the front line, is definitely worth more definitive investigation. And then I'll just mention other centers are investigating chemo-free strategies such as BTK inhibition plus anti-CD20 at MD Anderson. So trying to look ahead for mantle cell treatment in older patients, here are some really important trials that have been completed, but we don't have results yet. So the first one I'll mention is the SHINE trial, and this was for older mantle cell patients, randomized phase 3 trial. Everybody receives bendamustine rituximab as a backbone, and then patients are randomized to receive ibrutinib or placebo, and the ibrutinib is given until disease progression. And then Acerta conducted essentially an identical trial testing acalabrutinib on this BR backbone. Again, another randomized phase 3 clinical trial. The acalabrutinib is given until progression. Both of these trials are fully enrolled, but we do not yet have results. And then in the US cooperative group system, we completed a trial E1411, which tested bortezomib on a bendamustine rituximab backbone. And then all patients received rituximab maintenance for 2 years with or without lenalidomide. And we don't have the results from this trial yet either. So I think a question for the audience to think about, looking forward, if bendamustine rituximab plus BTK inhibition is a positive study for progression-free survival and not overall survival, does it become the new standard? And I think that will be up to each individual investigator to determine for themselves. For me personally, I think I want to see how big the magnitude of difference in progression-free survival is before I make that determination. Here's the US Intergroup trial that I mentioned. There were 4 arms. Everybody received bendamustine rituximab. Half the patients received bortezomib, which is the V in the induction, and then half the patients received lenalidomide combined with their rituximab maintenance therapy. And we just don't have enough events yet to report on this trial, but we are anxious to develop the next intergroup trial in mantle cell lymphoma, but we're really awaiting results from SHINE, the Acerta trial, and this trial E1411. There are some ongoing phase 2 trials in older mantle cell patients. In ECOG, we are doing a phase 2 trial of bendamustine rituximab combined with venetoclax. MD Anderson is doing window trials of ibrutinib plus rituximab. These trials have been reported at meetings but not yet published. And then Beijing, who's the company who makes zanubrutinib, is testing zanubrutinib rituximab against bendamustine rituximab in a phase 3 non-inferiority trial, and that trial is enrolling patients currently. So back to standard care options. Here's a question for the audience. You can answer this in your head. Maintenance rituximab has been shown to improve overall survival in mantle cell lymphoma. The answer is yes. There are 2 examples of this in older patients who received R-CHOP as an induction. This was published in the New England Journal of Medicine several years ago, and you can see in the upper right the remission duration difference, and in the bottom the overall survival difference where rituximab improved survival compared to interferon maintenance. And then maintenance rituximab has also been shown to improve overall survival after intensive therapy. This was published in the New England Journal of Medicine just a few years ago now, looking at rituximab after autologous stem cell transplantation in younger mantle cell patients. In the upper right, you see the progression-free survival advantage for the rituximab maintenance, and in the bottom right, you see the overall survival. So 2 important trials demonstrating really that maintenance rituximab appears to be highly beneficial in mantle cell lymphoma. There's still a number of questions, such as optimal duration, 2 years like we do in follicular, 3 years like they did in the mantle cell trial, or even longer durations. In the older mantle cell patient, they did it until disease progression. So the Optimal duration is really unknown. And then another unknown is, does the induction therapy matter? It is controversial to give maintenance rituximab after bendamustine. There is one randomized clinical trial that was rather small that suggests no benefit, but another retrospective analysis suggested there was. And so this is kind of a fundamental question given how commonly BR is used in mantle cell, and this question needs more study. So let's shift now and talk about the management of younger fit mantle cell patients. I'm declaring these patients as anyone age 65 or under. Most of the European trials have used this age as a cut point for eligibility purpose. And I'm defining intensive treatment as anything that includes autologous stem cell transplant or anything that uses intensive chemotherapy like hyper-CVAD with alternating R-methotrexate. So this, again, is just a question that you can answer in your head. Here are some options for young, fit mantle cell patients, and what is your favorite? All of these regimens are used around the country right now. Hyper-CVAD, R-CHOP with alternating R-DHAP, R-DHAP followed by stem cell transplant, the Nordic regimen. I know some centers just use bendamustine rituximab followed by stem cell transplant, and I know some centers that do not routinely include the stem cell transplant and just use BR followed by maintenance rituximab. So really a wide variety of management strategies for younger mantle cell patients right now. If you look at the literature, the best results have been achieved with regimens that include some version of high-dose cytarabine in the induction combined with autologous stem cell transplant consolidation. I've summarized 3 trials here, and the median progression-free survival in each of these trials is in the 7 to 9 year range. So these are really the best results we have to date for different frontline strategies. I do think it's important to point out to the audience, though, it has not been conclusively proven that the incorporation of autologous stem cell transplant in first remission improves overall survival. It most certainly improves progression-free survival, i.e. remission duration. But here was a really interesting study published in the JCO last year, a pooled analysis where lots of centers pooled their data. And in the red curves, we can see younger patients who received stem cell transplant, and the blue curves are young patients who did not receive stem cell transplant. And if you focus your attention on panel D in the bottom right, they did a propensity score weighted analysis where they tried to balance the patients for important baseline characteristics. And when that exercise is done, the overall survival advantage from stem cell transplant is not seen. So this is why it's probably not, or it's not mandatory that patients receive stem cell transplantation. I would consider it an option. So trying to summarize where we're at with standard therapy, when it is time to treat a younger mantle cell patient, most investigators will recommend an intensive strategy designed to maximize the length of the first remission. The median now appears to be over 7 years. That gives you hopefully many years where your patient is free of needing any treatment. That gives the field several years to find better ways to treat relapsed mantle cell lymphoma. And certainly your patients are only going to get older, they're only going to get less healthy, and so saving intensive options for later may not be in your patient's best interest. And of course, now we're recommending maintenance rituximab routinely. But as I mentioned, given lack of proven overall survival benefit, it is okay to recommend a non-intensive treatment strategy to these younger patients if that's their preference. So looking ahead, at trials, trying to define new standards for younger mantle cell patients. I'll just mention a few strategies underway. We have a U.S. Intergroup Trial, EA 4151, looking at a transplant question. We have another Intergroup Trial, 4181, testing an induction question. We have the Triangle Trial in Europe, and then we have the MD Anderson Window Trial. So let me just show you those in a little more detail. Here's the schema for 4151. This is for younger patients. They can receive any induction therapy. And if the patients achieve complete remission based on PET, that's MRD negative based upon next generation sequencing, they're then randomized, and that's in the upper right. And the randomization for the MRD negative CR patients is to auto stem cell transplant plus 3 years of maintenance rituximab, or maintenance rituximab without the stem cell transplant. Asking the question, if you've already achieved a deep, high quality remission, is the stem cell transplant still absolutely necessary? Patients who do not achieve MRD negativity or do not achieve a CR are automatically assigned to the stem cell transplant, and that's shown in the bottom right. This is an ongoing trial that's accruing very well across the country right now. Begs the question then, how do you best get to transplant? And as I mentioned earlier, the US practice patterns are really all over the map with all of these regimens in use. In developing a trial to test targeted agents, we really needed a North American standard. And so we selected this regimen that was developed at Dana-Farber. It's 3 cycles of bendamustine rituximab followed by 3 cycles of cytarabine rituximab. They did a pilot showing really outstanding outcomes with short follow-up. And then we wanted to add a novel agent to that backbone. And I've just summarized here some of the response rates and remission durations for the different novel agents. Dr. Martin's going to talk more about these in his talk, so I won't focus on this, but just including this so you have it in your slides. But the novel agent we selected was acalabrutinib. And so we have 3 arms in our induction trial. We're using this VRCR backbone, and that's a standard arm. And then arm 2 is that VRCR backbone combined with acalabrutinib. And then we have a third arm, which is just bendamustine rituximab, no high-dose cytarabine, but including the acalabrutinib. So this trial is open and enrolling in the U.S. cooperative group system, and the primary endpoint will be the MRD negative CR rate. So patients can actually participate in this trial and then participate in the transplant trial that I showed you a minute ago. They can do both studies. This is the Triangle trial, which is being done in Europe. This is a very important study that is testing BTK inhibition in younger patients. And again, it's a 3-arm study. They're using their standard induction, R-CHOP with alternating R-DHAP, followed by autologous stem cell transplant. That's shown in the upper box. But then they have 2 experimental arms. In the middle arm, you can see ibrutinib is added to the induction therapy, and then it follows the stem cell transplant as 2 years of maintenance therapy. And then they have a third arm in which the ibrutinib is also added in the induction and included at maintenance, but the stem cell transplant is subtracted from the regimen. So this trial is open and enrolling in Europe as we speak, and I think this is a very important trial that should add to the field. So just to conclude, outcomes are improving in mantle cell lymphoma. This is probably a combination of a number of factors that have come into play in the last 15 years. Older patients can be managed reasonably well with non-intensive treatment strategies. The first remission should last well over 3 years nowadays with bendamustine rituximab-based therapy. There are many trials looking to add to that VR backbone, including trials adding BTK inhibition. I think important future trials will try to clarify the role for lenalidomide in the front line. We're doing a trial now adding venetoclax to that BR backbone, and then the group at MD Anderson is testing, quote, chemo-free strategies. Younger patients can achieve very long remissions right now with intensive strategies, and there are ongoing trials that will test the role for MRD assessments to allow more personalized approaches to patients. And then other trials are incorporating novel agents such as BTK inhibition, including being tested with stem cell transplant as well as instead of stem cell transplant. And with that, I'll stop, and I will be happy to take any questions during the Q&A session coming up later.